the topics today. So we are going to be trying to understand about frequently occurring diseases, and then a second session wherein we'll go into little depth about why cardiovascular diseases, how cardiovascular diseases, and what implications it has for claims management. So coming to these basics, so let us now continue. Yeah. So what we need to understand for this session today is, first, let us understand what is adjudication. Because finally, whatever we are going to be talking right now is with the intention of understanding about adjudication. So adjudication basically is we are going to be talking about how we add judgment. So that addition of judgment is with the intention of application of the terms and conditions of the contract which is existing between the insurer and the insured persons. So we'll be going through those terms and conditions, and based on that, we are taking a judgment whether what claim the customer is putting up, is it within the scope of the contract which is signed by us. So that's what adjudication is. We add, and what we add is a judgment. But we have to be very careful with this judgment, because whatever we decide, it's going to have an overall impact on what is the outgo for us as insurance company. Now, when we talk of outgoes, definitely there are two factors which are determining it. One definitely is the incidence rate. So it could be small, it could be big, or it could be pandemic, like we have seen last year in COVID-19. And the second aspect is the treatment costs. So both these together is something which is affecting our total claims value. And we have to understand, when we are talking about these frequently occurring diseases, how even if the claim value may be small, the treatment cost will be small, but because the pandemic is there or because the incidence is very high, the multiplier effect is there, which results into a total claims value which is very, very high and exhausting. Now, before 2020, when we had no COVID-19 at all, I'm talking about what I'll say ages to earlier, when we never thought of COVID-19, the top 5 diseases would never have infectious claims coming in it. But what has seen in the financial year 2021 and 21-22 also is that it's the infectious diseases which has become a number one contributor. And cardiovascular disease, which used to be number one contributor or within the top 2 always, is now pushed to the second and the third levels. Whether you go for any particular corporate policy analysis, a particular underwriting office analysis, divisional office level, regional office level, head office level, or even at the IRDA level, the industry level. So these frequent changes are going to happen. But comparatively, the COVID claim cost, now where we are most of the time paying, I'll say, home care treatment also under force from IRDA. I'm using the word under force from IRDA, because if you had to go strictly abiding by the definitions of what home care treatment is in even the Corona Kavach policies, or even I'll say regular Mediclaim policies which are issued wherein such treatment would have come under the domiciliary clause, then 95% of the claims which you are paying currently would not have been paid. But then, because of regulatory requirements and instructions, you have been paying it. So all this put together is something which creates an issue. And when we are talking to the adjudication team, we have to make them aware of what the implications are going to be. And simultaneously, with those implications, we have to arrive at what could be the solutions, how the losses could be minimized. Because finally, that loss minimization is very important. If the losses are going to continue, then why would anyone be continuing in the business itself? So the role of an adjudicator is very important, because they create, they make, or at times break the companies as well. And that is why I come to this, what else, a standard word which I always tell everyone. the errors in adjudication are going to be proportional to the profitability, whether it is a TPA or an insurance company. Because even for a TPA, when the errors are captured, then there are penalties applied. So the profitability of the TPA is going to go down. And for insurance company, definitely it is a loss, because finally they are paying something out of their pocket, and considering the huge extent of business which we are having, each insurance company, it's not at all possible for them to audit each and every claim and find out errors and then have it penalized. So they do bear a significant proportion of the losses as well. And finally, being an industry, when we have within the industry discussions, many a times mistakes happen, we accept mistakes, chalta hai attitude comes to picture. But we forget the long picture, that in the long term, these small mistakes which we see today, when they are going to be added up, they are going to be a huge loss. I'm just saying few of the pointers of what mistakes generally happen. Now, since it is more of conservative claims, I'm talking about mistakes which you are seeing actually happening in conservative claims, wherein the number of days for which the patient is actually hospitalized and that which are claimed is completely not in sync at all. But due to the huge volumes, it gets missed out. So even if on an average we were paying say 1 day extra towards each claim, with an average per day claim size of around say 3,000 rupees, just think how many claims at the industry level we are paying. In one of the calculations, we found that it is turning out to be somewhere around 10 crores per day. That's the huge outcome when we are talking about at the overall industry level. That's a huge sum. That is what is happening. We have patients who are stable, but then they're still shown hospitalized in ICU setup, and they get paid for the ICU charges. In spite of incomplete documentation or same handwriting being visible in all the documents, the claims get paid without queries. Now, there's a separate session on fraud abuse, so I'll not be going into detail of that. Investigation reports, when everywhere it is mentioned, they have to be from registered diagnostic centers, properly authorized, signed, stamped by a professional, qualified professional, wherein qualified professional, qualified doctor is defined in each and every policy. Still we end up paying claims wherein the reports are coming from a DMLT pathology technician. There are evidences coming from the investigation reports or where photographs are made available for certain projects or for certain private insurance companies who insist on getting photographs. And there is an evidence that a treatment or a protocol or a surgery which is being asked and what is actually done is different. But still the benefits of doubt and the volumes come into picture and no questions get asked. Prolonged hospitalizations are going, and we are ending up paying, wherein people just want to stay in the hospital setup. Humne premium pay kiya hai, we have paid premium, we now need to make use of it. Diagnostic investigation reports not available, small size ticket size claims, 2,000, 3,000, pay it off. Patients getting directly discharged from ICU and no questions asked. While the good medical practices say that if the patient is not critical, then he has to go into a step down ICU or an HDU, then a routine ward for a monitoring purpose, and then discharge from there. But no one is looking into it this nowadays. This is what the claims audits that we are doing, cross audits we are doing for certain insurance companies, we are coming out with such findings. And field investigations, especially now with COVID-19, they seem to have taken a backseat. Most of the people are not going into the depths of investigations which used to be happening. In fact, when you have this fraud and abuse session, that will be covered further. So these are the reasons why we have to be aware of how to manage these frequently occurring claims, so that at least we prevent these 5 or 6 types of errors. So that is my objective, that by the end of the day today, you should not be doing such errors if you are processing claims, or you should be able to capture such errors from the processing team whom you are observing, whom you are supervising or monitoring or going in for audit any point of a time. So that's the objective with which we discuss. But before understanding what, you also need to understand कि भाई bills होते क्या है? Because unless we understand the type of bills, we will not be able to understand how to minimize these losses. So let us understand. So basically, if you go through the hospital industry and insurance industry together, you will find it's a mix and merge of different kinds of hospitals. So now the topmost priorities is being given to the PPN hospitals. So in this concept was institutionalized under the leadership of Siga Sampath sir. PPN used to be labeled, the full form was Preferred Provider Network. I'm stressing on preferred. So there were clear intentions when this concept was started that we will be selecting certain providers as preferred on the basis of better value which they give to us in our network. So better value would be in terms of lowered rates, better discounts, and freebies. And in return, what these hospitals would be getting is, since they should not have losses, a better volume in terms of there would be restricted network. So the number of footfalls to these hospitals is supposed to increase and the volume is likely to offset the value. So the hospitals will be able to utilize their bare capacity, and against that, their cost is going to come down. So that is what the PPN hospital as a concept was historically. But it has got diluted. And now PPN practically, if we see, has become packaged provider network. You have a session on networking, as if I'm not wrong. So Dr. Vishwajit has been with us when this concept was started with Sega Sampath sir. So he would be adding more value to it. But yes, now we are, most of the time what I see the TPS or even the insurance companies doing is, this is our package rate, you accept it, you accept this package, initially 40, then it becomes 75, then 150, 175, now 200 packages, you are our PPN hospital. Even private insurance companies who have got in-house processing and who are giving smart select options, there also the networking team is concentrating more on, can I get package. But then package is just one of the billing systems. If you see the billing patterns, I've kept it at 4th level. And there are reasons behind it. Then we have the empaneled medical hospitals. So hospitals which are network, but who are not working on the PPN concept or the packaged concept. You have certain hospitals which are a part of the mass health insurance schemes, PMJY, or certain state-specific schemes like Mukhyamantri Amrutam or Atal Amrit Yojana in Assam, or the CMCHIS in Tamil Nadu. And then you have that still a significant universe of non-empaneled hospitals, for whom volumes or service on cashless to the patient does not make any difference, because they know that patients come to them for treatment and they don't want to get into hassles of credit. Because they hear from their other colleagues, credit business, ye risk, wo risk, they have to write off. That's an operational risk, which they don't take. And that is the reason why still our cashless ratios, if you go to any insurance company or even the latest IRDA reports, they have not crossed 50% when it comes to volume. I'm not talking about the value. Value-wise, definitely it is higher, because somehow or the other, the average cashless claim size is always high. Now we'll be, if time permits, understanding why that is always high as part of this session today itself. And this is all happening when actually the providers who are supposed to be helping us in service to our beneficiaries with whom we have signed contract are very less. In India, it is just 0.7 per 1,000 population, while WHO is recommending 5. And that too gets distorted because most of these are in Delhi, Mumbai, Chennai, Bangalore, where we have the ratio of somewhere around 3-4 per 1,000. And in the rural areas, it drops down to around 0.5, 0.6 population. And that is where, when we are talking of going to the next level, or one of the commonest discussions you will find in the industry going on, even within your offices nowadays, is the missing middle. Now, what is that missing middle? Yes, there is a missing middle who are not covered, but then from where are you going to give them the services? Unless you have all the hospitals available, that missing middle may only come on paper, but practically they will still be going in for reimbursements. And that is where these billing patterns come into picture. So you have this line item wise billing, very, very proper billing. A hospital has a proper set of identified tariff, and for each service they would be identified. So room rent fixed, whether it is insurance company A, whether it is a cash patient B, or whether it is a TPA C, it's standard. My charges for visit are standard. My charges for auscultation are fixed. My charges for IV drips are fixed. My charges for IV line insertion is fixed. So whatever service I give, I have a fixed line item wise fixed charge, and it is available and it is billed irrespectively who the patient is. Line item wise billing. And that is what you will find that the countries which are very advanced in healthcare, say US healthcare, this happens very frequently there. And that is why you will find that they have got the CPT coding as well. Codification of procedures and therapeutics. India, we are still behind. I hope that someday in coming 2 to 3 years, we will be moving to the CPT coding level as well. But then till that time, we first need to understand what are all those procedures, what are all those therapeutics, what are all those treatments, standardized. CGHS has been doing a wonderful job since decades. They have identified so many treatments and services. And even today, when you have this, say, unspecified claim being asked by a hospital, even in a PMJY scheme setup where they have not got this identified procedure, the reference is given. If you go through the claims manual of NHA, National Health Authority, they say that the calculation for that unspecified package has to be based on the treatment which is nearly similar with any other package in the scheme, or if not, then with charges which are contracted for by the government in schemes such as CGHS. These are the exact words. So we have been having this. Only thing is, at the commercial insurance level, somehow we have not gone to that level. I remember we used to have discussions in 2014 itself that now the next thing after PPN we should be talking about is diagnostic charges fixations. A hemogram, when it is billed for an LIC patient pre-policy health checkup, you get it for 50 rupees. When it is being billed by a cash patient, you get it for 100 rupees. When it is billed in an OPD in a tertiary care hospital, it is 200 rupees. In a general ward, it is 250 rupees. Private ward, it is 300 rupees. And special wards is going up to 400 and 500 rupees. The ingredients for doing the test, the machine to do the test is one and the same. Then why this differentiation? That's a question. That's an area. And that is where in this commonly occurring claims, you will find most of the expenses are going toward this diagnostic charges. So line item wise billing, transparency is there, standardization is there. Then you have procedure wise billing. Now when we say of procedure, let's take an example of a central line placement. Now central line placement, those who are not doctors in the audience today right now, suppose there's an issue with what I'll say, the fluctuation in the cardiac status, and the blood pressure is fluctuating. You need to monitor, and you also need to have certain what I'll say medications going fast. So what generally is done is an access is created wherein you have these central lines placed either from your jugular vessels or subclavian vessels or from your radial vessels and going directly to your cardiac locations. So they help us in better and quick monitoring and quick revival. Now this is a single procedure. but then it has got many line items. So there would be an incision, there would be a placement, there would be flushing of the access which is being created, then there will be resuturing, and then there will be care, and then there would be what I'll say infusion which is being given. Now, if line item billing was to happen, then all these four would have four different codes, four different charges. But in procedure wise billing, central line placement, that's it. And the procedure is done. That's procedure wise billing. And then we have this per diem billing. Per diem billing wherein it is a per day billing which is being done. Now, this is generally has been in existence in CGHS, RSBY, government health projects. In commercial insurance, it came into picture when government authorities started negotiating and restricting the charges to be paid for certain diseases like COVID. Wherein they said on a per day basis, this is the maximum that you will pay. In a general ward, X amount, in an ICU, Y amount, ICU with ventilator, Z amount. And that would be inclusive of all the routine investigations, visits, care, monitoring, blah, blah, blah things. And then small asterisk, exclusion, high-end medications and diagnostics not covered. And that's it, everything over. Because now the hospitals have got that word there and they know what to bill now. So though you are giving a per day billing, plus all these additional charges, if the same bill were to come with a line item or maybe a procedure, the cost would have remained less. But yes, in certain cases, it helps like PMJY schemes or CMCHI schemes or Atal Amrit Yojanas, wherein you have per day 1,500 rupees for general ward, to 2,000 rupees in certain states, 3,000 for ICU or 2,500 in certain states, with ventilator 5,000 XYZ amounts. So you know that this is fixed amount that you get. The hospital also has got no choice, and they bill it and they get paid for it. Or another example of this per diem billing would be neonatal care packages. Now, most of you who have been working in the government health scheme sectors, you would find that the NHA has created around 5 different levels of packages for neonatal care. So you have basic neonatal care, then you have advanced neonatal care, then you have critical neonatal care, and then you have what I will say special critical care. And all these have got different rates, right? From 500 rupees, 3,000 rupees, 4,000 rupees, 5,000 rupees, and then 7,000 rupees. But then the indications are also given. When, in what condition of the baby, the neonate, that package is to be paid. So either it is on the basis of birth weight, or it is either on the basis of, say, the criticality. Whether the person is having ventilator support required, yes, no, how many hours. Then that highest package, no, then you go to the lower package. Sepsis, yes, no, no, then you go to the lower package. But then, so you see the claims and you will be shocked. And I have seen it happening with most of the TPAs, that this simply hospital is asking for something day 1 that is relevant, day 3 onwards it is not relevant, but it is getting paid the same for the next continuous 10 days. And you, me, who are paying income tax based on which all these treatments are being subsidized, are bearing the losses. And that is why it is very, very important that we at adjudication level understand that whatever we are paying is not someone else's money, it is my money. When that thought will come, what I'm going to show next, you will be able to implement perfectly. Then you have fully loaded packages like what we have discussed for PPN. In most of the cases, except certain where we have still given that asterisk and L2 is X-law and PMJY schemes. But again, here abuses happen. So when we are going to be seeing cardiovascular disease, I am keeping this topic little aside. That time I'm going to tell how that abuse happens for fully loaded packages. But it's very wonderful case study which I'm going to be showing there. And then we have open billing, wherein there is no restriction. If my enemy is coming to my hospital, I'll bill him bomb. If my friend is coming to my hospital, I'll bill him only minimal. There's no restriction. My room rent will vary from TPA to insurance company to cash patient, within cash patients also. My surgery charges, all my charges will vary. That is open billing. And there is no restriction, no questions asked policy. Now, with all these complications, we have to still ensure that across these common elements that we see, the costs have to be maintained. Because, see, incidence is something which is not in our control. It's only the treatment cost part which is in your control, in my control. And incidence to a certain extent, if we go into how to prevent hospitalization. But still, in India, that is a topic under discussion since last 4 or 5 years, how we can have case managements, how we can have care managements to reduce the incidences. Till that time comes in, we'll still have to concentrate on that treatment cost wala slab only. And then that overall claims cost could be controlled. So whenever you get any claim, practically you have to do certain steps. And these are common across all elements. I call it the 9-step ladder. And this is what you have to go sequentially. Whenever you get any claim at the cashless level, you will have around the first 4 steps and 5 steps which are required at the pre-authorization level, and at the final level, final discharge billing level, all the 9 steps of this ladder will come into picture, and claim level, definitely all these are going to come. So what do I do in this is, any claim, any disease, anything coming to you, the very first question is the need of hospitalization justified? The very first question. That's what I have to ask. Need of hospitalization justification. So if my hospitalization is justified, then I can relax. Okay, hospitalization justified, and we can think about it. Now, when is a hospitalization required? So there are certain good medical practices. If any treatment is going to be given or a care plan is going to be given which cannot be given on an OP, outpatient. I have used certain short forms here. So OP stands for outpatient. Part A, the treatment cannot be given on outpatient. 2, the situation or the criticality of the person is such that there's a risk pathophysiologically that he may require critical care any moment, because the vitals are fluctuating. When we talk of vitals, vitals means your blood pressure, your temperature, your heart rate, your respiratory rate, your urine outputs. So these are 5 basic important vitals that we are talking about. There are other vitals also. And then definitely your status of consciousness. So there's the risk probability, considering the evolution, how the patient is evolving, as can be seen from my history of the patient, that this is likely to happen and I may have to intervene. That is second. Third, certain treatments cannot be done on OP level at all. Certain medicines are not available at OP level. For example, let us take the example of COVID, where unfortunately, even today, I cannot guaranteedly say what is the treatment of COVID if a patient comes to me. But yes, someone has told, this authority has told, that authority has approved, you need to give injection remdesivir. Now, injection remdesivir on an OP basis, little risky, because we don't know what the reactions are likely to be. And it is not available in tablet form. So I have to have him hospitalized. Immunoglobulin injections, chemotherapeutic injections. It's just to ensure that that immediate risk, that immediate critical outcome which can happen has to be thwarted. So need of hospitalization. So is the documentation which is given to me of the history of the patient, his current examination findings, indicating anywhere that a hospitalization is required? That's the first question I come to. And for that, what I see in my claims papers, what I see in my pre-authorization form is the history of the HOPI, history of presenting illness. HOPI is history of presenting illness. History of presenting illness and the examination findings together are going to tell me what is the differential diagnosis and what is the likely care plan which is going to be required. Step 1 done. I move to the next step. What was the efforts to give the care on an outpatient basis? Because unless it is a critical ailment, like I have got a myocardial infarction, there are changes in my ECG. If I'm only having fever, why should I immediately go into an IP care? And you will see commonly occurring diseases, it's pyrexia which are the most commonly claimed diseases. Fever. So what was my previous outpatient care? Why has it failed? Is it failed or not failed? Or just because the patient has come to me, sir, fever tha 3 din se, I touch, I find 100 Fahrenheit. I say you require to be given injection paracetamol. I'm giving you injection paracetamol. You will be hospitalized. I'll have you under observation. But sir, why have we not tried oral medications? Why have we not tried to arrive at what is the cause for the fever? All that is possible on outpatient care basis. So what was the outpatient care plan and its result? That's the second thing which I see. The third thing is now the step ladder. I have seen requirement to hai, outpatient mein fail ho gaya hai. But what am I going to give if he's getting hospitalized? So what is my planned care? What is my care plan? See, these first 4 pages of any hospitalization of any hospital across India are very important. If you are able to read these 4 pages and read between the lines of these 4 pages, you will arrive at a perfect adjudication decision. So when I'm training doctors, I train them right from this, what we were trained in our colleges, in physiology, history taking, examination. Third year, I'm starting from my first year, one of the second subject. So even in claims adjudication, when you are training the adjudicators, you have to train them from that date. Reinforce ho jata hai. Arey, they also feel good. I am not out of my clinical touch. Otherwise, most of the time, doctors who join the sector, their friends, their relatives, kya kar raha hai tu insurance mein? Are you selling policies? And even they feel ki, what am I doing? So you need to give them this confidence. You are not doing anything else. You are doing clinical decision only. You are working for the clinical decision support system. And that is what the future is. We'll be seeing it in one of the slides today itself. So what is the care plan? And whether that care plan is justifiable for what I have seen in the presenting complaints, the history of presenting illness, the examination findings, the supporting diagnostic result. So whether all that together is justifying the care. I'll come with one of the common ailments for which we get claims, hypertensive emergencies or accelerated hypertension. Oh, again, it's a cardiovascular, so let me touch it there. Let us take example of, say, a fever there. Now, if my fever is 101 Fahrenheit, my OP care was given for 3-4 days with antibiotics, oral antibiotics, antipyretics, and still it is not reduced. And my diagnostic reports are suggesting deranged hemograph reports, and my fever profile, which is done, fever panel report, it is showing certain, say, abnormalities like, say, Vidal hai, malaria hai, something or that. But then what my care plan is going to be? Am I going to be giving him any IV medications? What my protocol is going to be of his hourly monitoring of temperature, respiratory rates, whether I'm going to be going ahead with sponging or not. I hope I have been with everyone. Okay. So that's the execution evidence care plan. So then you will get the patient hospitalized. Then now comes your final bill. So based on these three parameters, you are going to be giving the decision at the pre-authorization level, because you don't get anything else. When it comes to the claims level, now you will get the other 6 steps of the ladder. And yes, the 9th step of the ladder does come into the picture at the pre-authorization level as well. Whether is the treatment, care plan, or diagnosis anywhere related to any kind of an exclusion in the policy. So that is something which you have to look at. So if it is not an exclusion in the policy, then you need not worry at all. So that is what we have to be looking at. Now comes to the final billing or at the claims level. So within the hospitalization, there has to be an evidence of improvement. The improvement is not आज medicine दिया कल improve हो गया and now the patient is fit. No, it's a gradual change in the physiology of the patient, and that would be seen by you in your TPR charts, your nursing notes. So you have to be very, very careful. So that is where you have to be looking at the execution, the diagnostic evidences of the improvement. And most importantly, when you are at the cashless authorization level, all the intimation has been received by you at the claim intimation level. Many good TPAs I have seen, especially the big TPAs, they have this system of following up with the patient 3 days, 4 days after the intimation as well, to confirm where the patient is. Is he still hospitalized or discharged or not? So basically, it's an indirect way of controlling the length of stay in the hospital. So that is very important. So at the final bill level, I have to ensure that whatever is the length of stay being asked, it was relevant. Otherwise, I have to question it back to the hospital. If the patient was okay 2 days ago, why are you still continue to have him in hospital? The 8th step is the billing. It has to be as per the agreed tariff. So agreed tariff will be the contracted tariff rates. Let us now see its implication on your common diseases. So pyrexia, that is fevers. So it could be malaria, it could be pyrexia of unknown origin, it could be dengue, etc. So you will have these patients, these claims coming in, wherein there will be documentation fever not relieved by treatment, hospitalization, IV medications required. But the auditor in you, the adjudicator in you, has to wake up. What was the evidence of the treatment given which has failed? Whether the diagnostic reports are really suggesting the existence of such disease, or whether it is question mark, suspected dengue, suspected malaria. It does not take more than 1 hour to confirm this diagnosis. And the medication which is being given, is it relevant? So you have a patient of malaria, confirmed malaria as per the diagnostic report, and if you are not giving any anti-malarial medication, are we not able to see it? I have found nearly 20% of the claims of malaria in whatever audits I have done till now, which should be more than 1.5 to 2 lakhs still in last few years. These basic things are missing, and because of work pressure, we end up approving them. A fever tha, jada fever tha, it has to be paid. But then antibiotic is not treatment of choice for malaria, right? So it is an indication that it is a plan. So we'll continue with this mobile device only now. So that was about conservative treatments. Now, when it comes to the surgical part, the most common claims that we see at the surgical part, followed by your total knee replacements and total hip replacements, then fracture claims, PTCA or the coronary and CABGs, hysterectomies, septoplasties, and appendectomy, cholecystectomies. So what we have to look at all these things are 3 particular differences which we have not seen in the conservative part. One is definitely going to be what is the indication for the surgery. Now, no one would like to undergo knife unless it is absolutely necessary. So the indications have to be clearly established as per the standard treatment guidelines. Second is, if any surgery is happening, there are two things which happen, three things. One would be very simple, there is just an exploration. So there is neither anything being taken out of the body nor anything being put in the body. So example would be wherein I am say going in for a laparoscopy normal, or wherein I am just having say suturing of some wound, or wherein I am say doing a close reduction of fractures. So I am not putting inside anything, neither I have taken anything outside of the body. So how do I take a decision? How do I add a judgment on such claims? Is one, I have to go back to what was the pre-procedure evidence that something like this is required. So it could be in the form of a radiological evidence, photographic evidence, or a personal visit or investigation report which is being removed. So whether it is say appendicectomy, whether it is cholecystectomy, whether it is hysterectomy, whether it is any tomy, you'll always ask for the histopathology evidence of that thing which is removed. Third aspect is, this also helps us to understand the level of surgery which has been done. So you will find that the surgical treatment cost when it comes to say hysterectomy is different, and the surgical treatment cost when it is hysterectomy with omentectomy with oophorectomy is different, and same cost when it is with all these three along with lymphadenectomy is further different. So you would like to have the understanding of what is actually done. So if that is confirmed, then it becomes profitable. So that is why you always ask for the hysterectomies. We have seen many a times that just because of this upcoding possibility which is there, the hospitals resist giving histopathology reports because that gives a direct evidence that they have indulged in abuse and done upcoding. So you have to be very particular and still insists on getting the histopathology reports, because that then gives you the control over your surgical commonly occurring claim costs. So to summarize, for surgical common diseases, you ask for the diagnostic evidence, you ask for the OT notes, and you ask for the operative evidence. So once you have all these three, if you start having certain what I call it as databases maintained at your level. So which are those databases which are to be maintained by us? Those I have summarized in this particular slide here. If it is visible to you, I hope it becomes visible. In any case, this presentation is going to be shared with all of you. So that time you will be able to revise it very easily. So you should have a database of your procedures, providers, high-end drugs, implants, inclusions. And at each insurance company level, at each underwriting office level, at TPA level, you should be coming out with health index. So that would be your average benchmark for the payout for a particular kind of a treatment. And that health index is going to be differing based on your cost of living index, your hospital type, the comorbidity which the patient has, any complications which are arising, the demographics of the patient, whether it is young, old, middle-aged, child, and what is the qualification and experience of the providers. So based on that, your health index will vary, So for all the commonly occurring diseases, you should have it built in your softwares. And you should always keep an eye out for abuses. So those abuses could be incidence rates, it could be utilizations, it could be physician database and utilization reviews, within family multiple hospitalizations, the number of emergency hospitalizations being asked by a particular provider, length of stay issues, complications beyond predefined targets, because when we are going into the second lecture today, we'll be talking about it now. So based on various triggers, scoring pattern, then his hospitalization to be scored, and if it is suspicious, then please put it up for investigations. So I was going to talk about dialysis, but I think we are getting late because of this connectivity issues. I'm sharing this slide because dialysis is again one of the claims where which is causing a huge losses to almost all the insurance companies and government schemes as well. So indications are basically only two. Either it could be acute renal failure or chronic renal failures. So you have to look at what are the indications in that also. And only in those cases the dialysis has to be paid. Certain documentation which has to be mandatorily asked for is the clinical notes, a recommendation by a nephrologist for the dialysis to be done, wherein it is clearly documented about the quantum and the frequency. Quantum, what we have seen as abuse is dialysis is generally they call the patient every second day for dialysis, but then they give a dialysis of only 2 hours or 1 hour. But ideally, if they were to give 4 hours dialysis, which is an ideal time span, then the frequency of dialysis would reduce, say, twice a week. And that will be loss making for them. So those dialysis centers generally indulge in this kind of abuse. So we at Payer, we should be careful because finally it is our money. And all such episodes, incidences have to be brought up further. Also, when you are having a dialysis package, then that package is inclusive of your quarterly tests and monthly iron ferritin injection as well. So you have to ensure that that is being given to the patient and he is not paying it out of pocket. So this was about this commonly occurring diseases. So what I will do is I'll put an end to it here. We'll have common question answer session in the next after the next presentation. So I'll